Welcome back to part 2 of our Neuro and Head Neck on-call recap. Last time, we covered the neurology and the head and neck infections. This time, we're on to hemorrhage and trauma. Same format as before. The protocol, the main findings and complications, the differentials, and a quick reporting template for each condition. Let's get stuck in. We start with intracerebral hemorrhage. Plain CT head and add a CTA if anything about it looks atypical. You'll see a homogeneous high-density hematoma with well-defined margins, surrounded by vasogenic edema. And the location tells you the cause. A deep bleed in the putamen, thalamus, or pons points to hypertension, whereas a lobar bleed in an elderly patient raises amyloid, or an underlying lesion. If you've done a CTA, look for the spot sign, which is contrast within the clot and means active extravasation. Complications to watch for are hematoma expansion, which the spot sign predicts, and hydrocephalus if blood extends into the ventricles. And a cerebellar bleed is the dangerous one. It can cone the tonsils quickly. Your differential is a hemorrhagic infarct, which has an underlying low-density infarct territory, or an underlying lesion, so suspect a tumor or vascular malformation if the site is atypical or the patient is young. Report the region, the size, any intraventricular extension, and any shift. Cerebellar and large lobar bleeds may need evacuating, so neurosurgery need to know. Next, we have the extradural hematoma. Plain CT head, and do look at the bone windows alongside the soft tissue. The classic story is a head injury, a lucid interval, then deterioration. That's an arterial bleed from the middle meningeal. You're looking for a biconvex, lentiform collection that is sharply demarcated. And the rule to remember is that it does not cross sutures, but it is the only hemorrhage that can cross a dural sinus. Around 2/3 are temporoparietal in that middle meningeal territory. If you see a swirl sign, mixed density within the clot, that's unclotted fresh blood, and it means active bleeding. The complication is mass effect and herniation, going subfalcine, then uncal, then tonsillar. The differential is really the subdural, which is crescentic, crosses sutures, and is limited by the dural reflections instead. This is time critical, but the prognosis is good with prompt evacuation, so get on the phone to neurosurgery. Confirm the fracture on your bone windows, and if it's being managed conservatively, arrange a short interval rescan. And its counterpart, the subdural hematoma. Plain CT head again, but do use subdural windows, because a thin bleed will happily blend in with the calvarium, and you'll miss it. Think falls, the elderly, the anticoagulated. Have a low threshold to scan, and remember it may present weeks later with confusion. You'll see a crescentic collection, concave on the inner surface, spreading over the hemisphere. It crosses sutures but is limited by the falx and tentorium. And the density tells you the age, hyperdense when acute, isodense between 3 and 21 days, then hypodense when chronic. Complications are mass effect and herniation, an acute on chronic bleed with fresh blood layering in an old collection, and the disproportionate shift, where the midline shift exceeds the clot width by more than 3 mm, which means there's severe underlying edema. Beyond the extradural, your differential is a hygroma, which is CSF density with no blood, or an empyema, which enhances in a septic patient. Symptomatic collections need evacuating. Craniotomy for acute, burr holes for chronic. And acute subdurals carry a high mortality, so flag them promptly. Moving to the subarachnoid space, plain CT head first, then CT angiography, arterial phase, arch to vertex. The trigger is that thunderclap, worst ever headache. You'll see hyperdense blood in the basal cisterns and sulci, classically suprasellar, and the location predicts the aneurysm. Sylvian points to the MCA, interhemispheric to the anterior communicating, interpeduncular to the basilar. Watch out though, because blood over the convexity suggests an AVM or a mycotic aneurysm rather than a berry. Complications are hydrocephalus, with temporal horn dilatation as the earliest sign, then vasospasm, causing delayed ischemia at 4 to 14 days, and rebleeding, which is a high risk until that aneurysm is secured. The mimic is pseudo-SAH, where diffuse cerebral edema makes the vessels and dura look relatively dense, but there's no true sulcal blood. Confirm with your CTA to define the aneurysm for clipping or coiling. And do remember, a negative CT with a strong clinical story still needs a lumbar puncture. Staying with trauma, we come to traumatic parenchymal brain injury. Plain CT head with wide windows, because the hemorrhages here can be small and subtle. And go to MRI if the CT is negative, but the patient doesn't fit. You'll see cortical contusions, patchy hemorrhagic foci with edema at the frontal and temporal poles. Look for the contra-coup injury on the opposite side, which is often worse than the coup. And diffuse axonal injury gives petechial hemorrhages at the grey-white junction, the corpus callosum and the brainstem. Complications are hematoma expansion, because contusions characteristically bloom on follow-up. Then herniation, and the big one, CT undercalls diffuse axonal injury. So if the imaging doesn't match the clinical picture, that mismatch warrants an MRI. The differentials are a hemorrhagic infarct, which sits in a vascular territory rather than a trauma predilection site, and an amyloid or hypertensive bleed, which is lobar or deep gray rather than cortical. Flag the mass effect, herniation, and edema. And remember, contusions expand, so a short interval rescan is often needed. Right, that's the brain covered. Now on to facial trauma, starting with facial fractures. CT facial bones, thin section with reformats, and 3D if it's complex. The one to know is the zygomaticomaxillary complex, or tripod fracture, disruption at the zygomaticofrontal, maxillary, and temporal sutures. The pitfall is the zygomatic arch, which is easily overlooked, and if you miss it, the face widens. Then look at the maxillary sinus walls, the nasal bones, and the mandible. And a hemosinus is a useful clue, because fluid in the maxillary sinus signals a fracture of an adjacent wall. Complications are orbital involvement, a septal hematoma, which needs draining to prevent necrosis, and the second mandibular fracture. Mandibles are commonly paired, so if you find one, go looking for another. The differential is an isolated arch fracture without the rest of the tripod, or a Lefort pattern, which is what we'll come to next. Displaced buttresses need fixation, so flag any orbital involvement, the septal hematoma, and that second mandibular fracture for maxillofacial. Which brings us to the Lefort fractures. Volumetric CT facial bones with reformats and 3D rendering. And the single thing to hold on to is the pterygoid plate. A pterygoid plate fracture is the common denominator. It is what establishes a Lefort pattern in the first place. From there, it's about the level. Lefort 1 is horizontal, through the maxilla above the teeth. Lefort 2 is pyramidal, through the maxilla, nasal bones, and medial orbital walls. And Lefort 3 is craniofacial separation, through the orbits, zygoma, and nasofrontal region. They're often asymmetric, so you can have different levels on each side. Complications are the airway and hemorrhage, which are your ATLS priorities, then orbital and globe injury, and a CSF leak with the higher levels. The differential is a ZMC fracture, which is a tripod without pterygoid involvement, so not a Lefort. Secure the airway first, then report the level on each side and the pterygoid involvement. 2 and 3 need skull base and orbital assessment. And finally, orbital trauma. Thin section CT orbits with coronal reformats, and do review the soft tissue, the globe, the lens, the retrobulbar space. The classic is the blowout fracture of the orbital floor, with fat herniating down as a teardrop. Look for inferior rectus entrapment, where the muscle becomes rounded and displaced, and that is a surgical urgency in children. Then check the globe itself for contour deformity, rupture, or a dislocated lens, and hunt for any radio-opaque foreign body. The complication that matters most is the retrobulbar hematoma. Intraconal blood with proptosis and stretching of the optic nerve is orbital compartment syndrome, and that's a sight-threatening emergency. Your differential is a naso-orbito-ethmoid fracture, which involves the medial canthus and distinguishes it from a simple nasal fracture. A retrobulbar hematoma with optic nerve compromise may need an emergency canthotomy, So ring ophthalmology. Flag any entrapment, globe rupture, and foreign bodies. And that's part 2 and the series done. We've now been through the main neurology, head and neck, and trauma conditions you'll meet on call. Best of luck on those night shifts.